The patients that we are about to examine have all been evaluated within the past several months. When we meet our patients for the first time, we usually do not know what pertinent findings may be present which provide clues to the diagnosis or perhaps make the diagnosis. Also, each day, we often do not know what specific cardiovascular problems or findings they will present to us. It is still true that the great majority of our patients can be diagnosed in the physician's office and at the bedside. This is part of what we call the fun of medicine. Let's examine our first patient. She is a 15-year-old girl who has had recurring episodes of paroxysmal atrial tachycardia. Except for being aware of a palpitation in her chest, she is asymptomatic. There is no other evidence of heart disease. Third left sternal border. She has normal splitting of the second heart sound. A grade 2 to 3 short mid-systolic murmur is also heard, which is characteristic of an innocent murmur. The second sound becomes split with inspiration and single with expiration. Listen to her breathing, which is inspiration, after which the splitting is evident. Now listen carefully for a faint murmur in mid-systole. It is short in duration and is typical of an innocent pulmonic systolic murmur. Now, let's listen to several other patients who have normal hearts. First, a 13-year-old boy referred for evaluation of his systolic murmur. Is it innocent or significant? Left sternal border. The second heart sound is normally split and widens with inspiration. A short, early to mid-systolic murmur is also present. Listen again. He also has a normal physiological third heart sound, which waxes and wanes in intensity. The innocent murmur is also heard here. Apex. A 21-year-old man who has normal splitting of his second heart sound. The splitting is easily heard with inspiration, and with expiration, the second sound is closely split or single, third left sternal border. Did you hear the innocent grade 2 systolic murmur? Let's listen specifically for it. Our next patient is a 17-year-old girl who is asymptomatic. She was also evaluated because of the finding of a systolic murmur, which is typically innocent. It is a grade 2 to 3 early to mid systolic. The second sound is normally split. It is wider with inspiration. Some sinus arrhythmia is also present. Third left sternal border. Our next patient is a middle-aged man who has an aortic diastolic murmur and an aortic ejection sound. He has a localized dilatation of his ascending aorta, and there is evidence of mild left ventricular enlargement on the X-ray and electrocardiogram. He has a typical high-pitched aortic diastolic murmur. Note the aortic systolic ejection sound, which can be confused with a split first sound. It does not decrease in intensity with inspiration. Between lower left sternal border and apex, the ejection sound is still well heard. The diastolic murmur is fainter here. Apex. Aortic ejection sounds are often well heard at the apex. This is a good example. Now, let's listen over the aortic area where the ejection sound is also easily detected. Third left sternal border. He was diagnosed as having a congenital bicuspid aortic valve. Cardiac catheterization also confirmed this diagnosis. Patients with a congenital bicuspid aortic valve are more likely to have stenosis rather than regurgitation as the predominant lesion, although some have mainly regurgitation, as in this patient. Both stenosis and regurgitation are frequent, and some have no murmurs, but only an aortic ejection sound. This middle-aged man has been diagnosed as having a congenital bicuspid aortic valve. The aortic ejection sound is easily heard. However, he has a very faint grade 1 to 2 early blowing aortic diastolic murmur. Did you detect that? We will now listen specifically for this with the diaphragm of the stethoscope at the third left sternal border, patient sitting upright, leaning forward, and the breath held in deep expiration. Condition is a faint aortic diastolic flow that we hear at the apex. Push. Let's now listen to other patients illustrating the spectrum of findings of the congenital bicuspid aortic valve. Our next patient is a 15-year-old girl who has a congenital bicuspid aortic valve. She is asymptomatic. Note the early systolic ejection sound and a grade 3 somewhat musical systolic murmur, lower left sternal border. Apex. Third left sternal border. The ejection sound is still well heard here, in addition to the aortic systolic murmur. Pulmonic. Aortic. Note the ejection sound and the systolic murmur are heard from the aortic area to the apex. Remember, as has been just demonstrated, Aortic events are often well heard at the apex. They also may be transmitted to the neck regions. Next, we will listen over the left carotid. The ejection sound and systolic murmur are present here also. One could rightly say that this systolic murmur that we have just heard is like the innocent murmur. This is true, except for one finding. There is no ejection sound with the innocent murmur, an example of which we will now hear. Now, back to our patient with a mild degree of stenosis of the congenital bicuspid aortic valve. The ejection sound is present in addition to the systolic murmur. Our next patient is a 15-year-old boy who illustrates another part of the spectrum of the auscultatory findings of the bicuspid aortic valve. He has a mild to moderate degree of regurgitation of the aortic valve. Note the aortic ejection sound, which does not change with respiration, and his grade 3 aortic diastolic murmur. He too is asymptomatic. Third left sternal border. Next, a 63-year-old man with severe advanced stenosis of the aortic valve. A systolic gradient over 100 millimeters of mercury was present on cardiac catheterization. The aortic murmur is well heard over the precordium from the aortic area to the apex. Aortic area. Pulmonic area. Third left sternal border. Apex. Now, a 6-year-old boy also having significant aortic stenosis, aortic area. Pulmonic area. And left sternal border. Apex. Our next patient has both aortic stenosis and regurgitation, aortic area. Pulmonic area. Left sternal border. Apex. Our next patient with aortic stenosis shows the aortic events well heard at the apex, aortic area. Pulmonic area. Left sternal border. Note ejection sound here. Apex. Note ejection sound plus a third sound in addition to the murmur. This lady is 28 years of age. She is 7 months pregnant, and we are listening over her abdomen. These are the normal fetal heart sounds of her unborn baby. We hear both a first and a second heart sound, and the heart rate is approximately 130. Now we can hear the heart sounds more easily. She was born 3 months ago. Her heart is normal, with a rate of about 130. Let's now return to the mother in her last trimester of pregnancy. She illustrates the usual frequent auscultatory findings. First, an innocent murmur of pregnancy. Probably 90% of ladies have an innocent murmur if it is carefully searched for. It may be heard over one or several areas of the precordium. Our patient had a typical grade 2 mid-systolic short murmur and was heard over the third left sternal border, pulmonic area, and aortic area. First, third left sternal border. Pulmonic area. Aortic area. We are now listening over the mother's abdomen, and a systolic murmur is heard in addition to the fetal heart sounds. This is a normal finding, more likely to be found in the second and third trimesters of pregnancy. This is her venous hum, which is an innocent, continuous murmur of pregnancy. We are listening over the right supraclavicular fossa in the neck, patient sitting upright and head turned with a stretch to the opposite direction. Gentle pressure over the jugular vein promptly obliterates the venous hum, leaving the normal heart sounds. Now, let's listen to the fetal heart sounds again. Our next patient is 8 months pregnant. Listen to her innocent systolic murmur. It is grade 3 intensity. It is short, occupying early to mid-systole, third left sternal border. She was referred for cardiac evaluation. She had a diagnosis of mitral valve prolapse. However, she had no evidence of mitral valve prolapse, but did have a normal physiological third heart sound, which probably had been confused with a systolic click, apex. Note innocent systolic murmur and the typical normal third heart sound. She also had a venous hum, an expected normal finding in pregnant women. Right supraclavicular fossa, neck on a stretch, and head turned to opposite direction. This is a 76-year-old gentleman who has had recurrent episodes of dizziness. His harsh systolic murmur that we will hear over the aortic area, precordium, and neck provides an immediate clue as to the etiology of his symptoms. He has aortic stenosis, which is his predominant lesion. In addition, he has a minimal degree of aortic regurgitation. His aortic valve is heavily calcified. We're over the aortic area and listen with the bell of the stethoscope. Note the harsh systolic murmur that peaks about mid-systole. The second sound is poorly heard. This harsh systolic murmur is also well heard here. He has a few premature ventricular beats, and after the pause, the murmur increases in intensity. This is characteristic of aortic stenosis, as contrasted with mitral regurgitation, where the murmur shows little change. Third left sternal border. The murmur increased after that premature beat. Do you hear the faint aortic diastolic murmur? We have now switched from the bell to the flat diaphragm of the stethoscope. The diastolic murmur is much better heard. Lower left sternal border. Between lower left sternal border and apex. Apex. This is the same aortic systolic murmur that is transmitted to the apex. Aortic sounds and murmurs are often well heard at the apex. As we have just heard, his murmur of aortic stenosis was widely transmitted over the precordium. This murmur of aortic stenosis is also usually heard well over areas in the neck. Left carotid, right carotid, suprasternal notch, left supraclavicular area, right supraclavicular area, right clavicle, left clavicle, Our patient has features of a severe degree of valvular aortic stenosis, which has also been documented on cardiac catheterization. He has a serious symptom related to his aortic stenosis, that of recurring dizziness. When a patient such as this has syncope and/or dizziness, replacement of his aortic valve at surgery should now be considered. Our patient is scheduled for surgery in a few days. This 76-year-old man has had 2 episodes of dizziness and near syncope. One occurred while he was walking along a street of Washington, D.C. He became dizzy, fell to the side of a building, and then slumped to the sidewalk. Another episode occurred while in a restaurant. He had to put his head between his legs, and after a few moments felt like his usual self. His arterial pulses had a slow rise, which were sustained longer than normal. A systolic thrill was palpated over the upper mid-precordium. The direction of this thrill was toward the right neck and shoulder region. Listen to his heart. First, aortic area. Lower left sternal border. Note the musical quality of this aortic systolic murmur here. Also, following a premature beat, there is an increase in intensity of the murmur. Apex. Back to aortic area. Operation was necessary as the next syncopal episode might result in death. We are now 6 days postoperative. A porcine valve has replaced his severely calcified stenotic aortic valve. Note the short grade 2 to 3 systolic murmur, which is a normal finding of this valve. Lower left sternal border. Apex. Third left sternal border. Aortic area. Unfortunately, he had a complication of infective endocarditis due to Staphylococcus on his porcine valve. We now hear a diastolic murmur of aortic regurgitation, which made reoperation necessary. Third left sternal border. Another aortic porcine valve was inserted. Our next patient, about 70 years of age, has a mild degree of aortic stenosis that may be present in the elderly. It has been referred to by some as the, quote, innocent murmur of the elderly, end of quote. Our patient is asymptomatic and has no left ventricular hypertrophy on the X-ray or the electrocardiogram. His aortic valve may have some calcium deposits, but functions well. His diagnosis can be easily made in the office or at the bedside. Aortic area. Pulmonic. Third left sternal border. Fourth left sternal border. apex. Note a more musical quality. This patient that we have just listened to illustrates that aortic events are well heard at the apex. Also, the innocent murmur of the elderly often has a musical or vibratory quality, particularly at the apex. As one cardiac pearl, if we examine a patient, usually a male who is in the older age group and has an emphysematous chest with increase in AP diameter, and here at the apex, always rule out aortic stenosis. This high-frequency musical murmur may be localized to the apex or the lower left sternal border.